The title of my talk today is Combination Therapies in ITP. This is my disclosures. First of all, we have to discuss what is a refractory ITP. Probably this is a term that is antique. We are not using it because probably a refractory ITP does not exist. It's a refractory to any drug you may be using when treating ITP. Probably, as you can see here, a bottle of pills with it's about to cry. I mean, I'm here to help you. The real refractory ITP is the multi-refractory ITP, when a patient is receiving a lot of drugs. Well, the refractory ITP is, the definitions of refractory ITP are quite antique. Among the RC group, we are trying to update these definitions. The no response is defined since 2009 as a platelet count less than 30,000 platelets per microliter, or a less than twofold increase in baseline platelet count or bleeding. The loss of complete response is a patient who has a platelet count lower than 100,000 per microliter or bleeding, if the patient is in CR, or less than 30,000 or less than twofold increase in baseline platelet count or bleeding for patients only in response. And the timing of assessment of response to ITP treatment is variable, depending on the type of treatment. I think that with intentions of education of the audience, this table is very important, because you can see here when a patient who is receiving a drug can be considered refractory to that drug. For example, prednisone or dexamethasone steroids. If a patient is receiving this drug for more than 2 weeks, probably the patient is refractory. IVIG or anti-D, 3 days. Rituximab, more or less 2 months. Splenectomy, 2 months also. Vincristine and vinblastine, 2 weeks. Danazol, 3 months. Thiazolprine, 3 months. Romiprostine, 2 weeks. And eltrombopag, 4 months. 4 weeks. If a patient is under eltrombopag for more than 4 weeks without a response, 30,000 platelets per microliter, double the baseline platelet count, no bleeding. You don't have that, probably you have to stop eltrombopag treatment in that patient. What is a corticosteroid dependence? So you know that corticosteroid dependence is quite similar to refractoriness. The corticosteroid dependence is the need for ongoing administration or repeated doses of corticosteroids for at least 2 months to maintain a platelet count higher than 30,000 per microliter and or to avoid bleeding. And the importance of this is that a patient who has a corticosteroid dependence is a corticosteroid non-responder. The definition of refractory ITP, all criteria must be met. This is translated, reported that way in the paper from Rodillero. Is a patient who fails to achieve at least response or suffers a loss of response after splenectomy. The refractory ITP is also the need for treatment, including low-dose steroids, to minimize the risk of clinically significant bleeding. On the contrary, patients who require on-demand or adjunctive therapy alone are not classified as refractory. Primary ITP must be confirmed by excluding any additional and related causes of thrombocytopenia. And on the contrary, the definition of response of patients who have previously demonstrated to be refractory. This definition of response is the ability to maintain a platelet count sufficient to prevent clinically significant bleeding, the ability to decrease toxic therapy, e.g. steroids, on the contrary, does not qualify for response, but should be reported. So this is standard definitions that we are currently updating. Probably they are not clear enough. What is a multi-refractory ITP nowadays? The definition of multi-refractory ITP was established by the French group in 2016, where patients with severe chronic ITP who are not responding to rituximab, splenectomy, and TPRAs. The TPRAs accepted and licensed in France at that day were romiplastin and eltrombopag. These TPRAs had to be used at the maximum approved dose of 10 micrograms. There is some typo there. 10 micrograms per kilo body weight per week for romiplastin, 75 milligrams per day for eltrombopag. And the multi-refractory ITP patient who could have achieved a transient response to steroids or IVIG, because these treatments were considered treatments of first line or rescue therapies. This cartoon is from this very manuscript from Mathieu. As you can see here, they had, in this first paper, they had 37 patients, multi-refractory patients. 24 of them, on the left, were primary ITP, 13 were secondary ITP. Regarding the primary ITP in the left, NGAS were 7 patients. No other pathological features were observed in 5, and isolated biological features of underlying autoimmunity that comes positive, or ANAS, antinuclear antibodies, were observed in 12 patients. On the right, they had 5 patients with a definite autoimmune disease, 7 patients with a malignant hematological disorder, and 1 patient with a clear agglutinin disease. And all of these, they had also biological features of underlying autoimmunity in 5 patients. And as a whole, at the end of the cartoon, you can see that the features of underlying autoimmunity was observed in 22 patients. These 37 patients, from these 37 patients, this cartoon excludes the 7 patients with a background of neoplastic hematology, and they have 30 patients now. From these 30 patients, they have 4 modules of therapy for them. On the left, supported IVIG steroids or no treatment was received by 8 patients, immunosuppressant therapy by 14, TPRAs plus immunosuppressants in 5, and TPRA and supported IVIG or corticosteroids in 3. And you can see here that in the first column of the 12 patients who received this treatment, all the patients, no of them responded. In second column, for 14 patients, only 1 achieved a complete response with 13 no responses. And the third column, they have 10 patients. From those patients, 5 achieved a CR, 3 no responses. And the final column, 5 no responses from 5 patients. So the best combination therapy for a patient who has not responded to splenectomy, rituximab, eltrombopag, and romiplastin is paradoxically the combination of TPRAs plus immunosuppressants. Obviously, from 2016, in 2023, there was an update and published by the same group. In this update, they had 39 patients, 77% of them achieved at least a response. After a median follow-up of 21 months, 63% were in response. So our colleagues from France, to stress the point that TPRAs plus immunosuppressants are probably the best combination for refractory people, multi-refractory people. Which combination therapies in refractory ITP do we have? This is a cartoon from Walid that I stole him once. The combination therapies, the advantages of the combination are higher responses, higher remission rates, quicker time to response. Disadvantages are the potential for increased toxicity and higher costs. This is also a cartoon from Walid. When we use the combination therapies, TPRA plus immunomodulation in third-line therapies in refractory ITP. And besides this combination to be the best one, I think that we can summarize here just a brief commentary of the multiple combinations we have to treat a patient in a combo therapy. In the pre-TPO era, we have, for example, only to comment briefly, the Boruchov scheme. They use IVIG, anti-D, Christinamine blastin, 17 patients with responses, 66% of responses, only 6% of thrombosis. And they use a maintenance treatment with danazol and azathioprine in 19 patients, 71% of responses, only 6% of ileus as major side effects. Gomez and Malaguer, the Mexican group, published in Blood in 2010 a combination of rituximab plus alemtuzumab in 11 patients, and the complete response was observed in 45% of patients. No side effects in kidney or liver were observed, but 18% of herpes simplex viruses infections and 36% of urinary tract infections, 9% of deaths. So this combination is probably too toxic to be used. And my preferred one that we have used this combination in our hospital 3-4 times is the combination of Arno, the combination of azathioprine, cyclosporine, and mofetil mycophenolate, 19 patients with a minimum only 11% of complete responses, but 63% of partial responses. The only point to take into account here is the 32% of infections. Figueroa combines a lot of drugs, probably too much: cyclophosphamide, prednisone, vincristine, procarbazine, etoposide. In 10 patients, achieving a complete response of 60%, and they attain 10% of thrombosis. Chaudhry combines vinblastine and danazol, achieving 38% of complete responses with remission in 25% of them. Hassan combines rituximab with other drugs such as cyclophosphamide, vincristine, prednisone, with major results. The best results are where they use only rituximab immunotherapy and the classical scheme of 375 milligrams per meter square weekly for weeks. Sorry for being so boring, sorry. In the when we had, sorry, I miss experiencing English. When we already had the TPOs, we have these schemes. One, published 2 treatment arms with a combination of RH TPO plus danazol versus danazol with a very good advantage in terms of response for the combination. QI combines RH TPO plus cyclosporine versus RH TPO with a best results with the combination also. Choi combines dexamethasone plus cyclosporine and rituximab afterwards with an excellent response, 60%, and only 5% of infections and 15% of hypertension. published in Blood 2015, the combination of rh-TPO plus rituximab, 45% of complete responses, 26% of infections, versus rituximab with 23% of complete responses. So this is only to mention, only to stress that there are many combo therapies when dealing with a multi-refractory ITP that are worse than the combination that the French group demonstrated to be the best, but we can use it if we don't have any other possibilities. Last combination is the paper that yesterday presented Sylvain, the paper from Mathieu Maevas published in Hematologica 2020, and the combination of rituximab plus belimumab, this anti-BAF antibody, and they observed close to 87% of initial overall response at week 12, with 9 patients achieving, 60% of patients achieving a CR, no side effects. So this combination we are expecting, as Sylvain commented yesterday, we are expecting the results because this combination was the basis for the new drugs combinations we are using now. We are in RCT now. This VIHIT-3 is the ianalumab, a new drug that is from Novartis. Ianalumab in third line in patients who are refractory to many drugs, patients who have received at least 2 prior lines of therapy is very good, but given the results of the VIHIT-3, they try to combine ianalumab with other drugs in the VIHIT-1 and the VIHIT-2 trials. The VIHIT-2 trial is the combination, it's a randomized study, is the combination of ianalumab plus eltrombopag, and the results are being submitted to publish in New England Journal of Medicine. We have also the combinations of avatrombopag plus fostamatinib. This combination has been several times reported by our colleague in Spain, Eva Mingot. This combination is a treatment for patients with multi-refractory immune thrombocytopenia. They collected 18 patients with 5 treatment lines as a median, and they have 15 days as a median time to response, obtain an excellent response of 83%, and the relapse rate was 27% only. So avatrombopag plus fostamatinib is currently a good opportunity to treat refractory patients. We are trying to combine, for example, in our center, eltrombopag with fostamatinib, and I must say my own experience is that this combination is quite similar in terms of efficacy. Well, we have new drugs for ITP, and the question arises that will these drugs be combined with other drugs in the future? Apparently, if you see the results of this drug, CM313, published in New England Journal of Medicine last year, probably this drug is designed to be used alone in monotherapy because they observe 95% of responses as in a monotherapy schedule. These patients had a median number of previous therapies 4, and the median time to response was also, this drug demonstrated to be a rapid and fast drug, 1 week. And regarding safety, the infusion-related reactions were observed in 32% of the patient, and upper respiratory tract infections in 32%, no more. These results are quite unbelievable, I must say, because 95%, wow, it results, I'm not politically correct, I don't know. Mezagitamab, the drug from Takeda, you can see here these drugs, the participants in the phase 2 trial. The participants receive once weekly subcutaneous drug or placebo for 8 doses, followed by 8 or more weeks of safety follow-up. As you can see here in the histogram and on the left, the best results in terms of efficacy were observed with the major dose of 600 milligrams. And regarding safety, the right column, with this drug, 14% of patients suffer adverse events, but adverse events severe, grade 3 or more, were observed even more in placebo arms. So, and this demonstrates that methaxitamab is a quite safe drug. And a point here that Jim is very happy with this drug. Probably he has reasons for that. The pirtobrutinib is a BTK inhibitor. Probably rilzabrutinib, the drug from Sanofi, is very good. Pirtobrutinib probably will be also good or even better. The design of the trial will be presented at the end of the morning by Walid Ghanima. So the final question is, could ITP be cured with monotherapies or combination therapies in the near future? Probably yes. And conclusions, we are searching the curation. I don't know if we are able to attain that. Conclusions on my talk: the ITP pathogenesis is very heterogeneous. For refractory patients, combination therapy may be more effective than single-agent therapy, besides the side effects. Successful combination therapies may include TPRA and medications with different mechanisms of action to inhibit platelet destruction. And since chronic ITP can involve more than just accelerated platelet destruction, 2 or more agents may be required in combination therapy to provide optimal, effective management. And thank you for your attention once again. Thank you for coming. Your support is needed. I really appreciate your help, your kindness, your love. Thank you very much.
Thanks, Thomas. Thank you. Nice talk, nice talk. Okay, open for questions. I think combinations are good, like TPOs. My favorite is TPO plus MMF. I think works well together, mycophenolate, but not full dose, just like 500 twice daily of mycophenolate with the TPOs. Saved us with a lot of patients.
You have a bias because you are the most experienced people with the use of mycophenolate as third line. So.
But it's a good drug.
Yeah.
Of all the immunosuppressants, it's the best.
Mycophenolate is the immunosuppressant that you clearly must use in UK. You have the study, the light trial, with mycophenolate, the first line that published Charles Bradbury in New England recently, 2 years ago or something. So probably we can discuss a lot regarding the immunosuppressants, on the side effects of the bad tolerance, but the nausea, diarrhea.
Okay, questions? Come on. Everyone's too quiet. I'll have to come around the room with a microphone. Walid, you must have something. Yeah, come on. Have you got a microphone? Yeah. Okay.
I mean, before, my favorite combination was TPO MMF, and now fostamatinib MMF, and this.
Oh, really?
Yeah.
So Fosta plus MMF?
No, sorry, Fosta TPO. Fosta avatrombopag or Fosta ram.
Why is that?
It's much quicker. It acts, I mean, it's very quickly. With MMF, you have to wait a couple of months
speed
before you give up. But with fostamatinib, it's 1 to 2 weeks, you see the effect, then you start tapering one on another, and they works in a high number of patients. So that's my favorite combination now.
Yeah, I agree.
Very, very rarely that we use other combinations.
Yeah. Okay. Yeah, our results with eltrombopag instead of avatrombopag as partner for fostamatinib are, we don't have the data ready to publish, but we have 12 patients with first-line results also, and that the thrombosis risk decreases. I think that the thrombosis risk when using a thrombopag is lower.
Any other
Can we discuss
questions
of,
from
of this, obviously?
No.
But maybe another comment. How about combinations in the first line? I mean, there are the large number of trials in the first line.
What we discussed yesterday.
Yes, one of the first, I mean, the two first were rituximab, dexamethasone, and they were really successful. But no, except the Danish, they used this combination for some.
Well, I think as you well know, probably as clonal diseases, this is not a clonal disease, but this is a benign disease. But probably we are tending to, and there is a trend to use the major and best drugs in the first line. So in ITP, we are not using combination as first line, but as I discussed yesterday, probably in the near future will be using. Nobody knows what's better. Probably rituximab is a very good drug. You know that the problem with rituximab is that the durable response of rituximab from monotherapy is not very high, but probably the TPRAs does not have a very long-term durable response either. So,
but I mean, my comment on that first, it would be very good to induce remission to start with, and the patient will become normalized platelet count and will not need to go to the hospital and do the platelet counts and follow up with all these things. This is one big advantage of, and the patients, of course they want remissions and no more treatment. This is one thing. The second, ianalumab first line is coming, and if it is the first line.
And the results of ianalumab and invited one are some.
It's not analyzed yet. I mean, I haven't seen
the
phase
no?
one. The two analyzed.
Oh, sorry.
Yeah, but and I assume that it will be as successful as two, and this will be approved for this indication. So it will. I think it will change our practice in a way if the payers are willing to pay for.
Yeah, this was we discussed probably. Nobody knows how many years will take to change from monotherapy to combinations in first line, but probably it will appear.
I think the reason monotherapy is not so good is because you don't know, within the patient, you don't know what's going on. So the chances of you actually addressing the issue within that patient is not 100%. So if you use multiple drugs, there's a chance that one of them might hit that bit, the pathophysiology, and then you see so the more drugs you add, I suspect, obviously, the higher the chance you're going to hit something that's going on. That's the problem when we're treating blind as we are with this disease or syndrome.
Unless they start blocking each other's mechanism.
Well, then, yeah. Okay, but I think maybe we can stop there because Ming, who is online, so maybe we can, if you're happy, Thomas, I don't think there's any more questions, but it's thought-provoking. Thank you so much.
Thank you.